Hello, welcome you all in Mystifying Medicine. So we continue with our past medicine series in the respiratory section. Today our topic of discussion is tuberculosis. This topic include in both of your respiratory and infectious disease section. So let's start. Tuberculosis features. Tuberculosis is the 9th leading cause of death worldwide. Pulmonary tuberculosis is an infectious disease caused by Mycobacterium tuberculosis. It is rarely may be due to Mycobacterium bovis or Mycobacterium africanum. In many cases, TB may remain dormant before it progresses to its active form. It is commonly involve the lungs and it is communicable in this form, but may affect almost any of the organ system, include lymph nodes, CNS, liver, bones, genitourinary tract, and gastrointestinal tract. But TB doesn't involve myocardium, skeletal muscle, thyroid, cornea, nails, and hair. So this is the extra point. TB is a notifiable disease. Tuberculosis affect the adults in their most of the productive years. Over the 95 years of cases, death are in developing countries. In the US, estimated 9.5 million people have a latent TB infection. Risk factors are, some are the strong and some are the weak. The people who lived in Asia, Latin America, Eastern Europe, Africa for years, exposure to any infectious TB case. People who are infected with HIV are 30 times more likely to develop active TB. Immunocompromised individuals, those who have diabetes, those who are on immunosuppressive therapies, malnourished patients, or with hematological malignancies. And other one is the silicosis. Remember this because in respiratory section, RCP may test by giving this scenario of silicosis and ask what is the most likely risk factor or what is the most likely cause of TB, and they give the scenario of silicosis. So remember this. This may be tested by the RCP in your exam. Apical fibrosis is other risk factor. And the risk factors that are weak are the malignancy, end-stage renal disease because it is also the immunocompromised state, IV drug use, malnutrition, alcoholism, congested residence, nursing homes, homeless shelters, and the smoking. And the common features are presence of risk factor, cough. Initially it is dry and later it becomes productive in 50% of patients. Cough, that is cough more than 2 weeks, and patient has a low-grade fever and the night sweats. If present, usually drenching. Anorexia, malaise may be noticed in hindsight after treatment. And the uncommon features are pleuritic chest pain, hemoptysis. Hemoptysis mostly occur when patient develop the complication like bronchiectasis or patient who not and those who have typically the advanced disease. Dyspnea, a late finding in setting of extensive lung destruction or the effusion. Weight loss, psychological symptoms like depression and hypomania. Because it is a chronic disease, so it may cause some of the psychological symptoms or the worries due to the prolonged treatment and the prolonged illness. Patient may be asymptomatic and the diagnosis made from the coincidental finding or the screening. And the hypoadrenalism. Remember this point, this is also important because most of the time the patient who have a disseminated TB or first time patient may present to you with the Addisonian crisis, like because adrenal glands are mostly infiltrated by the TB and that causes the secondary immunodeficiencies. So TB is the most common cause in the developing country of Addison disease. hypoadrenism that has features like hypotension, hypoglycemia, hyponatremia. So at the first time maybe presentation of the patient with the tuberculosis maybe the hypoadrenism or Addisonian crisis. So remember this. And somewhat a patient who has a prolonged treatment of disseminated tuberculosis or patient with meningeal TB, those who are on prolonged dose of taking prolonged doses of steroids, they may also, due to the withdrawal, because steroids causes the dyspeptic symptoms, so some of the patient, or it is taken like 3 to 4 tablets per day, so they avoid to take it and they left, and sometimes patient present to you with the Addisonian crisis due to the steroid drug withdrawal. Signs: chest examination may be normal in mild to moderate disease. Possible findings include crackles, bronchial breathing sounds, or amorphic breathing sounds, or the distant hollow breath sounds heard over the cavities. Clubbing if prolonged disease or long-standing or the extensive disease, erythema nodosum. So how will you investigate? If there's a clinical suspicious TB, suspicious of TB, the patient should be isolated, and the chest X-ray is an initial test in which fibronodular opacity is involved in the upper lobes. Remember this, on the chest, TB is an example of cavitary lesion, and also it causes the upper lobe fibrosis. So chest X-ray shows the fibronodular opacities in upper lobes with or without cavitation. Sputum AFP smear, about 3 samples should be taken, positive for acid-fast bacilli. Mostly we advise the morning samples because the bacteria divide within 24 hours, so morning samples are preferred for testing. Sputum culture, most sensitive and specific test, should always be performed positive in TB. Full blood count, rest WBC, mostly the lymphocytes and the low HP. NAT, nucleic acid amplification test, at least one of the sputum samples, positive for Mycobacterium tuberculosis. If AFP smear is positive, then go for the NAT, that is the gene expert. If gene expert is positive for the Mycobacterium tuberculosis, it is a confirmed test, and patient is definitely a diagnosed case of tuberculosis. It is recommended that all patients with TB have a HIV test within the 2 months of diagnosis of TB. Because in HIV patient, there is also a form of tuberculosis when CD count is less than around 50, the Mycobacterium avium complex. So when you go for the sputum for AFP, it detects the Mycobacterium, so it may be positive. So it is recommended for that all patients with TB have a HIV test within 2 months of the diagnosis of TB. If the diagnosis is clinical, then it should be stated. People who should be screened for the TB. For the screening purpose, actually we test through the Montox test, and Montox test is also rule out the latent TB and the active TB. So here's the screening for the TB. Include those born in the high incidence countries, HIV patients, IV drug users, healthcare worker, and who serve in the high risk population in the contact of individuals with the pulmonary TB. A tuberculin skin test, that is a Montox test, or interferon gamma release assay. Actually, interferon gamma release assay is done when Montox test results are equivocal. So for confirming that Montox test result, we perform interferon gamma release assay. That is the standard method for identifying the person infected with Mycobacterium. Screening persons other than the high risk population place a burden on resources, so therefore not recommended in every patient. For the management, they are the standard therapy. You can remember by the mnemonic, right? And this is a here we discuss about the active tuberculosis management. The initial phase of first 2 months, known as the initial phase. In this we give all 4 main drugs like rifampicin, isoniazid, pyrazinamide, and ethambutol. Ethambutol now it is counted in the standard treatment, but formerly it was added in the drug resistant conditions like MDR or HDR. Continuation phase for the next 4 months, rifampicin and isoniazid are used. For the treatment of latent tuberculosis, first 3 months of isoniazid. Okay, this is a treatment of active tuberculosis. In this, for the initial phase, in first 2 months we give our 4 drugs, and for the continuation phase we give the main drugs, that is the rifampicin and the isoniazid. And this is the treatment of latent tuberculosis. For the latent tuberculosis, we have 2 options: either give the isoniazid with the pyridoxine for the 3 months, or isoniazid, pyridoxine, and the rifampicin for 3 months, or isoniazid with pyridoxine for 6 months. And the patient with the meningeal tuberculosis, there is a prolonged treatment of 12 months with the addition of steroids. And also in this we give the streptomycin. Directly observed therapy is a 3 times a week dosing regime. It is actually the monitoring way of monitoring that patient was poor compliance or reluctant to take daily treatment. So for the monitoring purpose, government has announced the DOTS therapy. They can and count the tablet form and give to the handover to the patient, or appoint a personnel to them, or it may be a family member, and ask them to monitor that patient take properly every medication or not. And they can and they have a centers, and patient come and visit to that center daily, monthly, or checking. Weight checking is also monitored. And the complication of treatment, the immune reconstitution disease occur typically 3 to 6 weeks after the starting treatment, often present with the enlarging lymph nodes. And the adverse effects, remember these adverse effects are mostly tested in your pharmacological section, and RCP mostly tests the 4 drugs side effects in the different type of scenarios. They may give in scenario like patient is taking a medication and developed the swollen big toe, and visited to the rheumatologist, and he asked for the drugs. He was suffering from the TB. What is the drug? So it is the pyrazinamide. So and that causes the gout or hyperuricemia, or arthralgia or myalgia. And second one is the most important thing, the isoniazid causes the peripheral neuropathy. For that prevention we give the vitamin B6. This is also tested by the RCP. And other one, this scenario is also tested by, or RCP may test in the one-liner question, who is a liver enzyme inhibitor, or who is a potent liver enzyme inducer. So rifampicin is a potent liver enzyme inducer. And all the ATT drugs causes the hepatotoxicity. So patients who are taking the ATT, they are advised to check, or when they can want to follow up, they advise the LFTs to monitor the toxicity of drugs. And also orange secretions, don't forget about the orange secretions in the rifampicin. You have to consult the patient about the orange secretion, because when the patient start to take the R4 drugs, and when they notice about the orange urine or any secretion of the body that discolored as a orange, and they worried about that drug and avoid to take R4 drugs. So you have to consult the patient about these side effects when you prescribe the ATT. Ethambutol optic neuritis, you have to advise the check the real acuity before and during treatment. So tuberculosis screening and diagnosis, as I already told you that the Montauk's test is used for the screening purpose, mostly for the latent tuberculosis. So Montauk test is a technique that used to screen for latent tuberculosis. In the recent years, the interferon gamma antibodies test also been introduced. It is used in a number of specific situations, like Montauk test is positive or equivocal. It is an interferon gamma, as I already told you that if Montauk test is a positive or equivocal, for the confirmation you have to go for the interferon gamma blood test. And the people who are tuberculin test may be falsely negative. So how it is performed? 1.5 ml of 1 ratio 1000 purified protein derivative is injected intradermally, and after 2 to 3 days result should be read. Here you can see that here intradermally 2 to 3 days back injected, and there's a reaction. You can compare with this and the normal skin, there is some induration. So from 0 to about 15, it is marked as 15. Sorry. So interpretation is, if this induration is less than 6 mm, means it is a negative. So no significant hypersensitivity of tuberculin protein, means previously patient is unvaccinated, so you should give the BCG. If it is between the 6 to 15 mm, means it is positive and there is a hypersensitivity to tuberculous protein, so should not give the BCG because it is a live vaccine. If you give in the active infection, it may aggravate the condition. So maybe due to previous TB infection or the BCG, so it may be positive in 3 conditions. In this it is positive, so BCG should not be given. That's a definitive. But it is in this category, maybe it shows the previous infection or patient is vaccinated. More than 15 mm is a strongly positive, so it suggests the tuberculosis infection, means patient has an active infection. Okay, false negative. In the most of the immunocompromised state, it gives the false result, like miliary TB, sarcoidosis, HIV, lymphoma, or very younger age, less than 6 months. And there is a heat test which is not nowadays it is not performed. So diagnosis of active TB is on the basis of chest X-ray, is already we have mentioned that upper lobe cavitation is the classic finding of reactivation of TB, and also it shows a bilateral hilar lymphadenopathy. Sputum 3 specimen are needed. This is an expensive and ZN staining technique is used that shows the acid-fast bacilli. So AFT smear, all mycobacteria will stain positive, like non-tuberculous mycobacterium like Mycobacterium bovis or avium complex, all detected as a positive. So sensitivity is between the 50 to 80%. So it is decreased in individual with HIV around 20 to 30%. Sputum culture is the gold standard point of a membrane. More sensitive than the sputum smear, and the NET technique should be used to assess the drug sensitivity. And it also give you the idea of XDR and MDR, because it will give you the sensitivity. And other one is a NET that allows the rapid diagnosis within 3 to 24 hours, more sensitive than smear but less sensitive than culture. Tuberculosis type, there are the 2 types, primary TB or secondary TB. Primary TB that occurs in an early stage, and that becomes dormant for the most of the time when there's a compromised state, or a patient has such a immunocompromised state or repeated infection like diabetes or any chronic illness, it becomes reactivated, and that causes the secondary post-primary tuberculosis. Tuberculosis is an infection caused by the Mycobacterium tuberculosis that most commonly affect the lungs. Understanding the pathophysiology of TB can be difficult. The key is to differentiate between primary and the secondary disease. Primary tuberculosis, a non-immune host who is exposed to Mycobacterium tuberculosis may develop a primary infection of the lungs. A small lung lesion known as a gonophogus. Gonophogus is composed of tuberculin-laden macrophages. The combination of gonophogus with a hilar lymph node is known as the gon complex. In immunocompetent people, the initial lesion will usually heal and that causes the fibrosis. And those who are immunocompromised may develop the disseminated TB and known as the pulmonary tuberculosis. In the secondary post-primary tuberculosis, if host becomes immunocompromised, the initial infection may become deactivated. Means that gon complex is a dormant state, and when there's a state like immunocompromised person or those who are on immunosuppressive therapies or the chemotherapies, that foci become deactivated. Deactivated generally occur in the apex of lungs and may spread locally or to more distant sites. Possible causes of immunocompromise include immunosuppressive drugs including steroids, HIV, or malnutrition. And the lungs are the most common sites for secondary tuberculosis. Extrapulmonary infection occurs in certain areas. If it occurs in the CNS, so it causes this the tuberculous meningitis, that is the most serious complication. Vertebral bodies like the Coats disease, cervical lymph nodes that is named as a scrofolioderma, and renal or the GI tree. So this is the X-ray, and it involves the interstitium, which is the X-ray of miliary TB. So that's all about the tuberculosis. So this topic is almost covered your respiratory section as well as your infectious. So for more updates, like my channel and subscribe to Respiratory Medicine. Thank you so much.